Start our meeting. This meeting is called by me as a chair of public safety and my colleague, Patrona Joan Rouser, who's the chair of housing and preservation and homelessness. I'm joined here today by my colleague, Pat Hogan, Marty Nave, myself, and of course, Councilor Jones. To my left is Chief Russin and Neighborhood Business Development, Michael Collins. Good to see both of you. And of course here, there's a whole team here, deputy mayors here, and everybody, welcome. Today's meeting is in regards to the challenges that are being presented to our city through homelessness and the impact that it produces on the public safety side. So this is more of discussion to kind of figure out what are some of the strategic approach and working solution to this issue, as it is quite a challenge. Patrona, you want to add anything else?
No, not yet.
Okay. So we have folks here. We're gonna give it to you, and then you can walk us through, and we'll go from there.
Well, I guess I will add that just to expound on the homeless or unhoused population, also the mental health aspect and possibility of the drug addiction as well.
Excellent.
Thank you, Councilor. Really appreciate you getting this discussion on the docket. As you know, on Monday when we were in our police reform committee, we had a long discussion about this, so very happy to be here. Just to set the stage, this is, I'm preaching to the choir when I say this is a multifaceted issue and problem that we have to solve, not only on behalf of the individuals who are struggling in our community, but for the benefit of the community at large, the businesses, the residents. When it comes to downtown, the schools that we have downtown in particular and in other neighborhoods in our community. And it is both a public safety, as Deputy Chief Russin is going to talk about, as well as the coordinated effort of all the people that you see in this chamber. I'm so glad that they showed up today. I will also add that, and Deputy Chief will be talking about this, and you're well aware of this as far as the police reform, we really have been pushing the dial significantly on what we call diversionary response and how we can address homelessness, substance abuse, and mental health. Not necessarily, if not called for, because it is not a danger, there's no imminent danger by a sworn police officer, but by the network of human service agencies. So you are in really good hands. These two gentlemen are really at the forefront of this, along with Sue McMahon and the rest of Michael and the Chief's team. Thank you.
Okay. Thank you, Deputy Mayor. Yeah, so I'd just like to start with, the Deputy Mayor, Michael Collins, Sue McMahon, the city team has really been working on this for 3 years. As part of police reform, one of the goals was to find alternative responses, and you had touched on really the core is substance abuse, mental health, and homelessness. How do we take that from the system that we currently have at 911, where when you call 911, you have 3 primary responses: police, fire, and EMS. And really, we're trying to build a 4th lever as a community. And we're working very, very closely with our partners over at the county, and then also very, very closely with a lot of the folks that are in this room to build that 4th lever, to build a system that is ultimately trauma-informed, it's efficient, and it's dynamic. This changes day to day. This isn't something that you can have one meeting per month and be successful with. This is a conversation that at the city level and the county level, our partners that are in this room, we're having weekly meetings on these issues. We've seen significant progress, but we know we have much more work to do. So I certainly am happy to highlight some of the projects that we're working on now, answer questions on those, so I'll take a break after each one of them. But again, I'd really like to thank the folks that are in here with the city team, the county team, and then also the community teams, if you will, because a lot of them, I'm in more meetings with the folks that are in this room than I am with some of the folks that are inside of the 4 walls of the PSB. That's how much time and energy has been placed on this. You know, the first program, and we started this last year, was what we're calling our Friendly Faces program. This was a proposal to the county to the county's team that the deputy mayor and I had made, where we were seeing primarily from the downtown businesses, repeat calls on folks that were really small littering or low priority calls for service, or they weren't getting the a priority for police response. But we're seeing the same folks over and over and over again. And a lot of these folks were degrading in terms of their mental well-being, their substance abuse, homelessness. Things were not going in the right direction. So we created a program with the county where SPD funds 2 positions at the county level. There's a weekly meeting, and this meeting is to talk about the folks that are on this Friendly Faces program. We have approximately 20 to 25 folks that are on the list right now, and we're trying to make impacts on those folks' lives in a positive direction. So each week, every person is reviewed, their names, where they are. There's a new 2 new folks, Gary, and I apologize, I forget the second employee's name, that are going out and meeting with these folks on a regular basis. They're coordinating services, they're asking tough questions. Are we being efficient? Are we being dynamic? Are we pushing in the right directions? And then there's follow-up on the back end. Some of these folks, unfortunately, as much as we're trying to be trauma-informed about this, some of these folks, unfortunately, are creating a nuisance in and around the city, and we do have to pull the criminal justice lever, where we have to engage with our partners over at the DA's office and the judges. We had one individual who was arrested last year 17 times for littering in the downtown area. We just go around and turn over every garbage can in the downtown area. It costs tens of thousands of dollars for the downtown committee to clean up. DPW, the folks that Michael works with, we have to do something better. And this program actually is identifying, he's one of the first individuals that will be part of this program, where we're now using the DA's office to say, is this person competent to stand trial? If they're not competent to stand trial, is there something that we can do to get them some long-term care? Our goal is always to divert. We're not trying to criminalize this issue. We're trying to divert it at all intersections possible. I'll pause there for a second, but I'll draw a nexus to our next program, which is our panhandling initiative.
Okay, so.
Any follow-up question?
Yeah, so you said that you get SPD involved to see, or the sheriff department involved to see if they are capable to stand trial. But I think there are steps prior to that need to happen on city and state level. This is probably something that's beyond this room. One thing that I have dealt with in my own life is mental health issues, and with individuals in my family. And like you said, they cause havoc in the community, in their homes. But one of the issues is that individuals with mental health are able to advocate for themselves, and that needs to change. Because if individuals are not on their medication, but when SPD is called to assist families with this, and they are, they have the right to ask the individual, are they okay? And if they say yes, then there's nothing that you guys can do about that. And then they're left in the home, in the community, to run amok. And so for me, I know that, and I've said this several times, again, this is at the 80-foot level, and or 80,000-foot level. And I believe that you have programs, individuals with heart disease or individuals that have dialysis treatments. When they miss their appointments, they get well checks to see if they're okay. And I think that it needs to be in place for people with mental health, that if they are not showing up for appointments, that they are probably off their meds, and they're probably causing issues for their families and their communities. And that needs to be implemented where they too get well checks before it gets too far.
Can I follow up on that?
Yeah.
Yep. No, I totally agree. And we see that on a fairly frequent basis, is that somebody that is off their medication will say, no, I'm fine today. I don't need anything. I'm regulated right now. And in the moment, they can present as a fully functioning member of society, but 20 minutes later, it can certainly change. One of the areas that we've worked closely with the county is changing on how we do pickup orders for folks that, for instance, some of our community providers are seeing they are deregulated. They might be telling people on the street that they're totally regulated, but their service providers are telling us that. That's one of the significant changes that came, on the heels of police reform in 2022, 2023. I agree with you, though. It needs improvement. We've made a couple of steps, but we see that at the same time.
Yeah.
So this coordination of services is what we're doing together with all of the folks in the room? Okay.
How do you get the 24 individuals into the program? Is it mandatory or is it by choice?
It's a referral program. So if we have a district captain, or sometimes we get a call from a downtown, the community knows these folks, and they're our best eyes and ears a lot of times. Now, we have very proactive officers that are down in and around the downtown area, but this is spanning the whole city.
Yeah, that's
and
what I was
it's
saying.
the whole city, and we'll make anybody can make a referral. We have a referral form. It goes through Captain Milana, who's just really done an excellent job with this program, working with the county, and then they meet every Tuesday and they discuss each person that's on that on the referral program. There's no cap per se. 24 is just approximately the number that we're at. There's no cap, but we're really trying to go towards the folks that are the most deregulated, if you will.
And what's the level of contact, say twice a week, once a week, with these individuals, once they are referred into the program with the two employees?
It will depend based upon the number of services that they receive. So there's no, the county employees that are funded by SPD, they will go out, but they're also making contact to other service providers that are working, that might be worker. Because a lot of times what I find is overlap. There will be someone that will have multiple services at the same time, or maybe services is the right, engaged. There's many community-based programs that are engaged with the same individual. But they might go out and touch base on a Tuesday, one group, and they say, I'm totally fine today. And next day, somebody else sees them and they say, well, this seems a little bit different. So there's overlap in engagement. I think
Is this in the streets or in their place of residence, the engagement?
It could happen in both. Anecdotally, I would say the majority of it is happening in the street, and I think that's an important question that we ask as a community: is where are we doing our most amount of engagement, and are we directing those services in the places that we need? Right, the police department has been relied on for a very long period of time. Same with fire and EMS, a long time, for external, outside of a brick and mortar facility that could do inpatient treatment. And a lot of our service providers now, as we ask these questions, we're working on these pop-up events, but I know a lot of the folks that are in here, the In My Father's Kitchen and Helio and the mobile crisis, they're now going out and pushing out into the community. And that really, I think, is a huge step in the right direction. The problem is not in the four corners of a house. The problem is out in the community, in the streets, and that's where I think we all need to be. That's where our office has to be.
Where does CPEP play a role in Friendly Faces? There's individuals that constantly are in and out of there as well. So where do they play a part?
Yeah, so we work closely with CPEP's mobile crisis, but then we also work closely with with CPEP itself, their emergency psychiatric facility. So if we have someone that is ultimately on a pickup order for something like a 945, 958, which would be a mobile crisis pickup order, we will make direct contact with either their mobile crisis team, because we'll need their direct help if we're not using Liberty Resources or one of the other mobile crisis. So we'll have them in the field with us. But then we'll also make contact with the folks that are at the hospital. Hey, we have a person that we're sending up to CPEP, and we flag some of them that we think are a higher priority, or there's additional information that the police have that we want to share for referral to CPEP.
Can you work with somebody that it's not in your referral list, but you see and identified as somebody that needs help?
Yes.
You do everybody?
The referral program is 2 months old now at this point, maybe 10 weeks old. But anybody that we see, you get a 911 call about someone standing that is
That's my question.
that is standing on the side of a street, and they look like they're intoxicated or they're high and they're falling asleep and they're going into the roadway. I mean, of course, we're going to push into that as well too. And the officers have done a great job to push in with the mentality of, is there a service that we can get this person?
Could we hear some of the human services agencies in terms of their engagement as well to support SPD and the city? Could we hear some of their work? Yeah.
Good afternoon. I'm John, Executive Director, co-founder of In My Father's Kitchen. Thank you for hosting this. I think it's a wonderful thing. So we're in collaboration working with NBD in regards to receiving some funds from HUD to do some street outreach components that we do. We're also in wonderful partnership with SPD and the panhandling situation to address what we're doing as an agency. So twice a week, we're going out with street outreach. Like today, we went out with a medical provider from upstate. So we're taking care of folks who maybe don't have their medications and need to get on their medications if they want it. The doc prescribes it. Also doing a lot of wound care because of the drug addiction that's outside and the thing that's happening on people's skin. So we're addressing that issue. We're also doing engagement in regards to getting people on the coordinated entry housing list to get onto housing. We have the Higher Ground van that rolls out 4 days a week in partnership with Onondaga County and the City of Syracuse, totally funded project. Unfortunately, with that project, it's only 9 individuals per day, Monday through Thursday. So
They call it Higher Ground?
Higher Ground, yep. And it's an alternative to panhandling. It's a hand up, not a handout. So what'll end up happening if you're a panhandler or you're homeless, on Mondays and Thursdays, we're dealing strictly with folks on the street. On Tuesdays and Wednesdays, we're accessing the shelters. So we're picking up folks from all 3 shelters in the community, Tuesdays and Wednesdays, to give them an opportunity. But the main thing, other than being on the van and not panhandling, is there's case management on the van. So we're helping people get connected to their SNAP benefits, reconnected to their family, getting on medical treatment. If there's something going on legally with probation or parole, we navigate that by advocating for them. So it's building this relationship with the individuals at street level. Our work is strictly with folks that are outdoors, right? So under the bridge, an abandoned house, in the woods in a tent. Unfortunately, in the summer, the numbers go way up. We have a caseload of 80 going on, and I have 3 care managers here with me today. That's a big load to carry. And there's people at different levels of stages of where they want to comply with whatever they're trying to get help with. So my goal as an agency is to build this relationship with you to the point where you finally get to this point of surrender, I call it. I don't know when that's going to happen. We just want to be standing there when you say, I'm ready to make a change. And that's happened 371 times, helping people get into housing over the last 13 years. Unfortunately, 80 people have passed away in this work that I've been doing for 13 years. It's life and death outside. So I appreciate all this. The mental health is a really big challenge when someone's not taking their medication. So I'm thinking of a young man who hangs out by the regional market, schizophrenia, not taking his meds. We're connected with his mother. She told us what happened. He stopped taking his meds. He's out on the street. He doesn't want to take them. The challenge for us as an outreach provider is I can't supersede someone's free will choice to make those decisions. But I appreciate what you were saying about we need to relook at, especially with the mental health realm, coming up with another way of doing it. There was only one time in 13 years that we did 2 PC with someone. I had Dr. Sunny Aslam with me, a psychiatrist. One day, it was in the winter, gentleman under the bridge. He was a harm to himself, was in full manifestation of his schizophrenia, and was threatening harm to myself and the physician. We call SPD. He writes the order. That person was picked up, went to CPEP, took medication, and was a success story. He actually thanked the doctor for doing it. But that's an anomaly. That's like the rarity, but it is a tool that's rarely used. And because of civil rights and all these, it's like you said, it's a bigger conversation. But that's what we do as outreach. And I work with everyone that's in this room. We're just the tool on the ground, the boots on the ground. We connect to the housing provider, the mental health provider, the physician, Helio for addiction. They come out when a guy's on the higher ground van and they're expressing they want to go to detox or rehab. We make a phone call. They come out, they do an intake, and sometimes they leave right from the van. So they weren't panhandling. They got on the van, and next thing you know, they're in detox. Unfortunately, the challenge is the housing situation, right? So there's people on the list for a long time. And if you go to rehab or detox and you do a 28-day or 3-month program, where do you land when you come out? So there's a disconnect there because if you land back on the street, the more likelihood chances are you're going to relapse and get back into it. So that's kind of an overview of what we do. But working with SPD, the sergeant sends me an email when they're giving warnings first. And as for folks that are like in the medians, there's like, if you stand on the curb and on the side and you're not making trouble, then it's okay to hold the sign. But if you're in the middle of the road, like on Hiawatha Boulevard, you're going to get a warning, maybe a second warning. They bring out help to try to get them connected, and then they finally get a ticket. And he could maybe, the deputy chief could maybe express more of how that looks. But then I get the names of those folks that got ticketed or warned. And if it's someone that's in our wheelhouse and we start to have a conversation with them about, hey, you know, shouldn't be doing this, to try to guide them and give them guidance. So that's kind of what we do at In My Father's Kitchen.
Can I ask a question?
Yes, sir.
We talk all about this. There's two things we haven't discussed yet. How did they get there?
How did
they get there? How did a person, maybe 20 years old, 50 years old, how did he get in that position? Did they lose their job? Did they lose a loved one to a tragic accident? Did their house burn down? That hasn't been discussed. It takes one life-altering event to happen. I seen it to me. I seen it in my friends I lost. The same thing. Everything's fine. They got a job, and one day they lose their job. Depression sets in. They don't know what to do. And maybe old demons come in, and they roam the streets looking for a job. And now these people become vulnerable. They don't want to go back home. For some reason, their minds tell them stay on the streets, and someone gives them a joint, and it'll make life better. Give them a drug, make life better. You see, everyone has a story. When we were born, we didn't say, well, we're going to be like this. When I was a child and I would see a person like this, a homeless person, but how did they get there? And that issue hasn't been discussed. So when a person has a tragedy, loses a parent to a drunk driver, loses their home through no fault of their own, and they feel like no one's giving them a chance. There's no counselors available to help them. Okay? I believe everyone has a story, and I think if you talk to everyone, like the lady hangs out in front of the Samaritan Center in the middle of the road, or the people hang out in front of Hiawatha Boulevard, North Salina, like this guy was slipping on one foot where he could have been killed, and the story goes on and on and on and on. There was a story where I used to help this customer in my drugstore. His mother would drop him off in front of Rite Aid downtown, asking people for money. And he wore clothes better than people who are homeless. So we got an issue, but we got to bring it to the forefront. How did they get there?
Yeah.
Do we have counselors available?
Yeah.
How do we counsel? How do we help them?
Yeah, I think I hear your frustration, first of all, and I hear your concern, which is valid. I think everyone in this room, we hear the story behind the cardboard sign. Unfortunately, we hear the good, the bad, the ugly, the trauma that's happened. You're talking about like childhood trauma. Things happen to people. We can't control the past, right? I can't help what happened to you before. I could just help you when you're standing in front of me and trying to move forward. To get people to acknowledge their trauma sometimes is a challenging thing. And that's a scary thing. That's why they're self-medicating sometimes with drugs, right? So you take away the drugs and you got to deal with what you're talking about. And it's a vicious cycle. So I hear you, and I would like to open it up to someone else. If someone.
Yeah, well, you know,
So,
John.
thank you for letting me share.
Chief. Thank you.
I wanted to ask some of the service providers, as far as the 28-day, 30-day detox programs, and then the recidivism for those situations, why hasn't the time frame changed? Why hasn't that, changed to a longer? Is that a insurance issue? Okay. All right.
There are programs that go beyond.
Yeah, but you have to do the first one and then,
Yes, yeah. There are programs that go beyond short-term detox. You can go into.
And you are?
Sorry,
Oh,
I'm
sorry.
Tanya Lyons. I oversee crisis services at Helio, but we have a million more programs than just crisis services that I don't have all the details on, but I can give you briefings on. So there are programs that go beyond short-term detox to answer your question, but yes, there's insurance barriers, there's diagnosis, drug of choice barriers, there's all sorts of different barriers that come into play, and also what John was saying with people's free will to undergo treatment. It's not often that we can mandate treatment. So as far as what we are doing with the vulnerable population in our community, we have a lot of different programs. So Tom's here from Outreach and Engagement. They are going out onto the streets to engage folks who are in need of SUD treatment, whether that's outpatient, detox, inpatient, just a friendly face to say, hey, you might not be ready today, but if you're ready tomorrow, give us a call, that type of thing. Tom, if you want to expand, you can partner up here.
Hi, I'm Tom Barnell. I'm the program director for Outreach and Engagement at Helio. Like Tanya said, we are the in-community substance use team where we try to connect people with treatment. What I think would be important to define here is people use the terms detox and inpatient as one thing. It's really not. And one thing that impacted us was the deletion of one of the services we used to be able to provide. So detox for my team means someone who is using a substance who, when they go through withdrawal, it's going to be a life-threatening situation. For us, that's normally opiates, fentanyl, or alcohol. If any other thing, cocaine, methamphetamine, things like that, that's what we consider inpatient. The difference is the detox is anywhere from 3 to 7 days, depending on how the individual reacts. The technical term for detox is medically supervised withdrawal services. That's what determines people get into detox. Otherwise, it's an inpatient situation. We used to have what was called, in addition to the medically supervised beds, we used to have it was called a medically monitored bed. So it was someone that was maybe using a lot of cocaine, did not qualify for detox to get in right away, but otherwise needed to be assessed and paid attention to closely. Those beds got taken away because the insurance didn't want to pay for them. Once those went away, my team ended up spending more time in the hospitals because that's where they go. Because they're going through, withdrawal is withdrawal. It's not fun, it's not painful, it's not a good thing to go through. But they ended up in the hospital, so that's where we ended up catching them. So if we had more of those types of beds, it would be a little bit more, we'd be able to get people in sooner. Right now, my average wait, if I do an inpatient referral, say I did one on Tanya and she was inpatient appropriate, depending on where she wants to go, because it is all patient driven, I'm looking at a 7 to 14 day wait for them just to get the bed. Mm-hmm. In the meantime, my team is peer and clinician, go out in teams. The peer specialists that I have, and much like in my father's kitchens folks, they're very good at staying in contact with folks, trying to keep them, engaged mm-hmm. and, ready to go to when that bed opens up. A lot of times that wait is just too long, mm-hmm. And people fall through the cracks.
So we did have Helio here a few months back, and two issues that we did raise was the fact that when people did come to you guys with fentanyl use, they were then sent from Helio to the hospital in an ambulance per se, frantically, I should say, that the possibility of overdose, and no one went with them. So when they were released from the hospital,
there's no follow-up.
Went wherever, and there is no follow-up. So had that changed, and the other thing when we spoke back then was about young adult services, where you have the younger population at this time that are higher numbers of usage. And when they're going into rehab, they're with older individuals and they really don't fit in. And so they don't stay, and then they're back on the streets, back into you guys, back and forth. So those two things were some things that we probably should have followed up on, but more or less the first one about the hospital situation.
Yeah, what I would say to your second point there is if there was an ability to, what happens, you mentioned recidivism, that type of thing before. What my team sees a lot is we will get people connected. They're very engaged. They do very well wherever we send them, whether it's one of our facilities, an out-of-state facilities, or a state ATC, whatever. They do very well. What happens is they come back to people, places, and things, and that's where it comes back to where things don't change. And a lot of that has to do with housing. We talked about it. We've talked about this before. A lot of it has to do with there's substance use and getting that or their mental health taken care of falls way down on the ladder to basic needs. They need a place to stay. They need a house. They need heat. They need food. So that's where we kind of lose it a little bit. And I agree. We could do a much better job of following up with the folks that do go to the hospital. Sometimes we are kind of handcuffed by consents and, quite frankly, people working for us. It's a hard position to maintain a full workforce.
I can actually speak to some new programming with that. So the reason why people have to go to the hospital after being Narcaned is because there's an opportunity for the Narcan to wear off and for them to overdose again in a short time period. So that's why the hospital is the best place for them to go. That's why they're sent to the hospital initially. As far as people going with them, we do have a couple of new initiatives happening. Helio was awarded the opioid settlement dollars from the city to create the Syracuse Crisis Intervention and Prevention Program. Part of that program is overdose response. At the same time, the Department of Health through the county also was awarded dollars to create an overdose response program. And so they had a little bit of a head start on us. So they're right now formulating connections and protocols that we will join in on once things are settled. The county's team will be operating Monday through Friday business hours, whereas the SCIP team will be operating Monday through Saturday, 9 a.m. to 9 p.m. So part of the goal of that is to attend overdose responses with EMS partners to, one, provide education and resources to those who were there with the overdose. Most people don't overdose and call 911 by themselves. And two, to then provide that follow-up from the hospital discharge. What can we do for you now? Where can we bring you? Is it detox? Is it inpatient? Is it outpatient? Whatever it is, can we help connect there? The SCIP program was born from a phone call a couple of years ago, the same issue that we're dealing with right now. People are congregating on the street. What can we do? How can we help? And a bunch of us got together and started doing these pop-up events where we're hitting the hot spots, we're hitting the large groups of people with all of our different areas of expertise to attempt to offer different resources. The SCIP team will be doing that on a daily basis. They will go out into the community, be boots on the ground. They'll respond to crisis calls if and when they come in, but when they're not responding to an actual crisis call, they will be interacting with business owners, helping provide education. They'll be interacting with these vulnerable folks that are on the streets. A lot of times when we talk about free will, people are scared. They don't know what treatment looks like. A lot of people are used to the idea of treatment being punitive. So we want to get away from that, and we think that if we show up every day, even if they're not willing to engage today, that doesn't mean they're not going to be willing to engage tomorrow. So we just want to keep showing up for them.
Is this SCIP program, I know you had a question.
Yeah, go ahead.
Okay. Is this SCIP program like tied into the mobile crisis?
So a little bit. So, okay, when we talk about mobile crisis, there's a few different layers here. We have two 1115 waivered mobile crisis programs in our county. We have the mobile crisis program that operates through CPEP that Deputy Chief Rustin was talking about earlier, and we have Liberty Resources mobile crisis program. Helio Health also has a mobile crisis program, but it's dedicated to our CCBHC clients. So as a CCBHC, we are required to offer 24/7 mobile crisis services to our established patients. So the other two teams respond to crisis calls through the 988, 211, and Crisis Connect systems, whereas we respond directly to our patients. So our SCIP team and our mobile crisis team are tied together, and we meet with the other mobile crisis teams every other week to collaborate on needs in the community.
Okay, so I think that is where I'm trying to get to, because the mobile crisis, from what I've heard through in my community, is not responsive to the needs of the people. Maybe because there's 3 and 4 different mobile crises and no one knows this. I didn't know that. I thought you contact SPD or they give you mobile crisis and it's one unit. So I didn't know there's multiple mobile crisis units. And 211, is that correct, 211? Is anybody here from 211? Because that's not useful at all.
Councilor Joan Rouser, you have hit on what is the key missing piece in all of this. You have a room full of these folks they're on the ground, they're meeting with folks and they're doing this. What has to happen is a coordinated effort of where we're going to go, how we're going to coordinate, how we're going to know who the friendly faces are, who needs attention. The Housing and Homeless Vulnerable Task Force, they are engaged in this. What has happened, Mark is being very, very humble. Because the reality of the matter is that coordination that he just described to you, he was doing. And then I said, we didn't hire you to do that. And so his brain, brilliant as it is, came up with this coordinated effort. And the ability for how can SPD engage in this process by contracting with the county for individuals that we can interact with specifically to do this outreach. We've held a coordinated meeting, literally breaking up that meeting last Friday at the time that staffing happened with all of these people in this room. Sue was amazing. But that coordination should not come from the city. So if there's one piece that's missing, is the ability to have one coordinating effort, willing to work with the county. We both are getting opioid funds, but that cannot rest on the shoulders of Mark Russin and SPD, or Mike Collins and NBD, or Sue McMahon. That is the missing piece.
So who is supposed to do that then? Because it seemed like all of you are doing some great, amazing stuff. And it seemed like there is no centralized point where everything can just...
Can we hear from the county?
Can we...
So is there
or Michael Collins. I think Michael Collins want to say something.
But so I can start it off.
Okay.
So Deputy Chief mentioned at the beginning, when you've called 911 previously, there's always been 3 responses. We have always had an ad hoc way of trying to make sure that for these events and for these people that don't fit into those 3 for what is the best response for them and for the community, how do we find a way forward? Because there's not an existing system to be able to do that. And so part of the reason that we were able to get hold of everybody so quickly is because we've been working really hard to make sure that not only is there a formal way to do this, but as we build it, we're also creating opportunities for everybody to work together. You all know, you have heard me say, you have all said to me, we're a service-rich community. And that has meant that we have a tremendous amount of ability to help for people that are in need. What we haven't always had is a way to do that with a single point of entry or multiple points of entry that all come into the same place. So as Deputy Chief has been working on everything that he's been working on to the pop-up events that Tanya mentioned earlier, what we started last year was creating these events so that not only were we hitting the hotspots, but we were doing it in a way that people that provide the complementary services, but we had never asked for them to show up together, would do so that they also are building the relationships and are understanding the network from an implementation standpoint. It's one thing for the executive directors to be able to understand it from, what financing do they have, what grants do they have compared to who else is doing it in the area. It's another thing for the people that are on the street to be able to understand that. And, many of us come from worlds where we've interacted in those nonprofits, run those nonprofits. And so if the larger the organization, the little bit more challenging that can be. And so this has created opportunities for that. And what that does is, when we're at our best, is it gives us a chance to listen. So what we've done with these pop-ups, and as Deputy Mayor has just said, is we come together, we do it, and then we get together separately. Or we get together at a separate time immediately afterwards to debrief. And it's not just for us to say, hey, here's what we saw, but most importantly, it's a chance for us to listen and for us to hear from the providers, this is what we need. And some of it is from us, some of it is from 80,000 feet above, some of it is from not so far away. So we've been working on this really since the beginning of the pandemic, when people first started calling in saying, I'm seeing all these people on the street, why am I seeing them? And we would reach out to In My Father's Kitchen, and Rescue Mission also has a homeless street outreach team. And what we learned was most of them were housed. This was an issue where people that had been finding a way to manage their struggles, mental health or addiction, those structures went away. And so they no longer had the tools at hand that had allowed them to be successful. And so it is from that we are building in a completely new system that existed 4 years ago. And so that's why we've been forced to be really creative, and we're incredibly fortunate to have all these partners in the community that have agreed to work with us in how we figure that out.
And before you say, I think Councilor Paniagua had something before we
I was just a
concluded
question
that.
on a comment that you made. You mentioned that an individual would potentially go through detox in 5-7 days, something like that, right? Depending on the individual. But if you identify that individual actually, for us to make a real wellness impact, needs more time than that, can they be put into long-term care consecutively from the detox? Do we lose something there in between? What happens?
So I would tell you it's possible, it's not probable. There's not enough bed space. That's why there's a wait for those inpatient beds. It does happen, but it's very rare.
In an ideal world, somebody would finish their medically supervised detox and go into a longer bed, but those beds are full.
So could I ask, you own 31 properties in the city, correct? I think that's it, 31
Sure.
properties. So some of those properties, none of them are housing, right, or are they?
We do have housing
So you
facilities.
have a bunch of people, so there is housing for folks who
Yes.
are in the second stage after they initially been.
Oh, you're talking about residential, okay, so yes.
That's farther down.
So we have, so ideally, somebody would
Do you have
go.
any just for my own edification here, do you have any properties in the suburbs?
Yeah, we do, Liverpool. Liverpool?
Couple, or 31, no, you don't have 31 in
that it?
Liverpool, right?
No.
Okay.
No,
Okay.
they're mostly in the city. So ideally, somebody would finish detox, go to a longer-term inpatient bed, and then go to a longer-term residential care facility.
So what do you have as far as housing goes? You have the second stage there that you
Well,
mentioned?
so we have residential, which is considered like an inpatient residential, and then we also have housing. We have 105 housing units. We have of HUD housing, and Lisa just looked up the data today. We actually have funding for 46 additional HUD units for these vulnerable folks who are out on the street. We don't have landlords that will rent apartments to this population right now. So part of the issue is we have the funding, we don't have the physical locations to house the
What
individuals.
Michael pointed out is it all boils down to housing a lot. Years ago, we used to have a lot of single-room occupancy in downtown Syracuse, which housed a lot of folks that were in dire circumstances like this. and
We
don't.
also lack security.
Correct.
Like on Catherine Street, where I've had constituents keep on calling me.
Yep.
People are going in by their homes, dealing with their drugs and other things that are going on Catherine Street in the backyard. Police officers have been going there back and forth. And what we need from you, we need better security just to help safeguard our communities, our neighbors, their children. because they're at risk too.
What kind of security from a mental health and substance use facility?
Security, like in the parking lot, because I had one resident called me again yesterday. She lives on Catherine Street, and they got dealing with drug issues, and they're doing the drugs in her backyard.
Yeah, so there's an assumption that the crowd of folks that congregate right there, it's like Willow, Catherine, Hickory,
Right.
are all Helio residents. Some of them are, but not all of them are. And some of those folks that do live in Helio housing live in independent apartments that are not as intensive as the initial stages of residential right after a detox and inpatient stay.
Well, I think the point is, I mean, every city I've studied, like Albuquerque, New Mexico, anybody who's embarked on this path, dealing with mental health problems starts with housing the people. And I think that's what we're trying to do with our housing strategies and all that. I mean, we're trying to like house people. And I think one other thing, I think CPEP is only at St. Joe's, right?
CPEP is only at St.
But it
Joe's,
used to
but
be
we
at
did.
Crouse too, right?
Nope, the only CPEP in our community has always been St. Joe's, but we did just open the intensive crisis
Wasn't there
stabilization
there was a
center.
place at Crouse?
There was
Trujillo?
a,
Trujillo?
yeah,
Okay.
There's something at
Not a
Upstate,
CPAP,
but
not
I
a
don't think it's
CPAP.
called CPAP.
there,
Well, they might have, but there was a detoxification ward up at Crouse.
so, the three, what they call 946 hospitals in the area are
I
downtown.
don't know the acronyms, but I know there was.
Right, so the three hospitals that provide inpatient psychiatric care are Upstate Downtown, Upstate Community, and St. Joe's. Crouse doesn't have an inpatient unit for psych care at this point. I don't know what they had in the past, yeah. But right now, those three hospitals offer, and then the crisis center.
I want us to come back to this centralization strategy, but I think, Reverend Alex, you have something. Please.
Just about the centralization really quickly.
Yeah.
There is a new position that the county just created in the past few months. It's the Director of Mental Health and Crisis Services. So that's a really new position, and the person that took that role is maybe 2 months, 3 months into the role. But I do envision that as kind of a central point of all of what we're talking about eventually. But again, that's a brand new position, so.
This is Andrea's position.
Yeah.
Yeah, so I was going to bring that up as well too. This is a new position, and Andrea had worked for Liberty Resources. Tanya and I met when she worked at Liberty Resources, then she went over to Helio. But that's Andrea has that position. She's working on a lot of the programs that I work on with the Friendly Faces stuff that we're doing in the school-based district, and really it's the coordination of mobile crises. There are a lot of mobile crisis teams that are in, I don't want to say a lot because we could use more, but there are plenty of them that folks don't know about it, and it's the coordination of it. And I think, I don't want to speak for Andrea, but that is really a lot of the work that she has done in the last 2 months. The coordination is going to be helpful, and really Andrea was a huge pick to get for that position. She's really a grinder, just like Tanya was when she was at Liberty Resources, just like a lot of the folks that are in this room.
Is there a consolidated paper somewhere that could be delivered to community centers and community places where people can access those services, that it's in one place and people know about it? Because to me, it seems like there are these services, people just don't know.
And just to speak to that, people, that's where I brought in 211, because people are told, call 211, and I've called 211. And 211 did nothing more than what I could have done myself, and it was very frustrating. So the answers that I needed at that time, it was prolonged to let me look through this and let me search through that. And I could have did that myself.
Hi, my name is Andrea Krolik-Swain. I am the Divisional Director for Mobile Crisis at Liberty Resources. I am new to my role in about the last year or so, and much to Deputy Chief Rustin's point, Andrea would be a really great resource to be able to work on this coordinated effort, given her tenure, along with Tanya with the Mobile Crisis Program. To your point, asking about the number of services and having some type of information, that is something that our crisis network group that Tanya mentioned earlier has actually identified as a need for the community, really being able to consolidate this information and be able to get it out to people We recently drafted and created a crisis services grid to help people identify who can respond to them, who they can talk to, and where they can go, to be able to really differentiate between the different levels of care, the resources that are in the community, and how you can access those. It's a newly created document, probably within the last 6 to 8 weeks or so, and it's our hope to be able to at least get that on the county website, so that way people can start to differentiate between those services and make the decision for themselves as to what would be most helpful based on their circumstances.
When do we see that getting out?
Yeah, we can certainly talk about that at our next meeting,
Okay.
which I believe is scheduled for Tuesday.
Okay.
And talk with the county about what logistics they need in order to be able to get it onto the county website and accessible to the public.
And will it have times,
Yes.
Oh, yeah.
and will it have times with it as well? Like if a service is only from
Yes.
working business hours?
So currently, it has the names of the organizations, eligibility criteria, a description of the services, the contact information, and hours of operation. It breaks down the populations that are served, so whether it is a mental health or substance use response, if they serve the lifespan, children or adults.
But we make sure that they make those information make their way to places like food pantry areas, as granular as it is. I think it's important. Thank you. Reverend Alex. You can come back. Yeah.
Good afternoon. My name is Bernard Alex, pastor of the Victory Church and executive director of ministries outside the walls of Victory. I hear all of the wonderful plans of what can and what should be done and what the urgency is. And I put that in this paradigm that, well, what do we do in the meantime? I often say to staff, living in the meantime can be a mean time. And a lot of people that are out here are in that meantime. How do they manage? How do they navigate? This didn't just happen overnight. These are the seeds of a community disjointed and disconnected. When you have neighbors, organizations that don't know what each other is doing, we don't talk, we don't communicate, we've been siloed for sake of funding, for territorial reasons, and all of those things that we talk about. Those are some of the seeds. The seeds of families in need and struggle and parents not being there to parent. Those are some of the seeds. We can all start throwing them out, but we now are reaping the harvest. So what do we do in the meantime? It is my recommendation that, and this is not from it's completely non-sectarian, because I would share this with anybody. What we do in our facility is we stood in front and we walked 10 minutes, north, south, east, west, 10 minutes. And we started walking our way back. And we began to greet people and say hello and build relationship and start talking to them, such that when they're in need of food, they feel comfortable because they know the staff. When they're in crises, they know the staff. When they know by coming in to eat every Wednesday, free, good, home-cooked food from 12 to 1:30. There are tables set up at no charge. There are vans in the parking lot from ACR. There are tables and people outside serving ice cream sundaes, building a relationship in a community. Imagine if each faith center, however that be identified, took that same modality of walking out, developing relationship with the agencies that are within their neighborhood to be there at specific times so that we are doing a tiered service and not just giving food, because my other hat, the largest population of concentrated poverty in Onondaga County is in the town of DeWitt. Wonder why would I know that? So this is not just an urban issue. It's a community issue. So it is not just because of poverty. It's because of a community that is going through struggle and transition. So we have to address suburban, urban. We have to address those that are having a mental health issue, complicated and compounded by drug issues, disjointed from family and not being connected. We got to have a one-stop shop in neighborhoods at various times so that, and if the base be, because I just see it as a good base, faith center, community center, Walk outside so that the people in the community know you, because you will never reach someone's authentic concern until they can trust you with their concern.
Thank you, Bishop. Chief, you had something?
One of the things that I've seen is a roadblock in this, in the sharing of information, is the medical or HIPAA-protected information. The police department, when folks call 911, it's not as protected. We just know that the person is in crisis, right? We're not asking specific medical questions. So it's easier for us to share information, the contacts with all the groups that are in here. Like if we go out on this dangerous panhandling detail, it's very easy for me to share with John, hey, these are the folks that we engage with, because it's not the same. I'm not asking the same questions as a lot of the medical providers. Same thing if I have to call Tanya, or if I have to call the county about something. So that's one of the benefits that I have seen in the coordination of these efforts, is that as we're building this fourth lever from at the 911, really at the 911 system, to your point about 211, is how do we get the 911 call takers to be the folks that are saying, these are the services that are providing, this is how I can divert that call. But the 911 system, police, fire, and EMS, has been around for many, many, many years. This is what we're building, and that's what these weekly meetings are all about. And I have seen spin-off ideas from some of these things that we've been, collectively working on for a lot of years, but really in the last 3 years is a lot of that spin-off work. That's how we're building that fourth level. I think everybody that I've met with in this room, the goal is true alternative responses, where if you do call 911 or 211, there is a direct pipeline to the appropriate service. And sometimes it is going to be police, but a lot of times what I find is it's not police. It's one of the, the many folks that are in here, they have roadblocks as well too, where it doesn't make any sense that you get treatment or this initial treatment at the hospital, and then you go back out for 7 days. The success rate it's abysmal, right? That's a difficulty.
So if I call 911 and I know these conversations have happened before, but I haven't been a part of it. So if I call 911 and I'm having someone who has a mental health issue, I know that there was supposed to be a component of SPD and someone who works in that field to accompany them. How does that happen? Because I haven't seen that myself. I've only seen SPD. But I will say that they were nice. They weren't aggressive or anything like that.
That's good. That's good. Well, I'm sorry to interrupt you.
No. So I just wanted to know, what questions or wording do you need to say to the 911 dispatcher so that they are sending that
Right service.
Yeah.
Yeah. So I'm going to answer in two parts. The first, I'm going to start with the second half of your question. What needs to be said? This is part of the education of the community that we have gone out and we're educating folks on how the 911 system works, the priority ones, priority twos, priority threes that we've all talked about a lot, and then also what needs to be said so the right coding happens. That is community education, and that's a big component of this. When we work with the 911 system, it's a layered approach, right? The first thing that really is being assessed is there an immediate threat to the community? Generally speaking, is there a weapon? Is this person in the roadway? But there's an assessment process that happens at the 911 center. When we're sending resources there, one of the first things that we started to work on with the 911 center was crisis counselors. If there isn't an immediate threat, there is a crisis counselor that is embedded with the 911 center during our statistically highest time frame from 11 a.m. to 7 p.m. That was statistically our highest area where we're getting mental health related calls. And the crisis counselor will get on the phone and now start to de-escalate, connect resources. Sometimes it's not peer-to-peer support, but it is a service provider support for this individual. Sometimes they just want to call and talk to somebody. We have folks that call the 911 center hundreds of times a year just because they want to call and talk to a friendly face. So the crisis counselor is one avenue. The next avenue is our mobile crisis provider. So the folks that are in here, if it is a mental health crisis, it could be a direct call from SPD or from the 911 center to St. Joe's mobile crisis. It could be a connection with Liberty Resources. It could be Helio. It could be someone. It could be the VA where they have I don't want to say mobile crisis, but they could be interacting with someone that we know is a veteran and that they have a level of crisis. It could be someone that is unhoused at the time, and we'd be making direct connections with John and his team. If SPD does get on scene, and sometimes we're getting on scene too frequently, that's part of this progress, this evolution. But if we get on scene, that's why we have crisis intervention trained officers, right? We made a big push probably 5 years ago to have 20% of the patrol workforce. We're above that now, but certified as CIT-related officers. There's 2 new programs that are coming online right now that is born out of the work that we have been doing. One is we're working with our ambulatory partners to have mobile crisis personnel embedded with the ambulance service. So to have them going out, because sometimes you do have a medical component and a mental health component at the same time, that is something that we're hoping. We've been working with the county, the 911 center, our ambulatory partners, Liberty Resources, a lot of the mobile crisis, to get them embedded. Hopefully that will start the pilot program will start in the fall of this year. SPD had a grant that we worked on with the grant department to rewrite that we're going to have SPD officers embedded with mobile crisis counselors. As I walked in here today, we're talking with the service provider about, hey, what's the contract going to look like? How are we going to do that? That's work that we've been doing. Because some of them will be above an ambulance and a crisis counselor and be to the threshold of 2 police officers and a crisis counselor. So I think it's a layered approach. I hate to give you the long-winded, but we're trying to throw efficient resources at this problem while also being dynamic in our approach. So hopefully that answers your question.
Yeah.
I feel like I talk loud enough without it. You asked, what do people need to say to get the right person, right? A really important thing that I don't think a lot of people know about yet is who's the right person to call. So if you are suffering from just a mental health emergency that has no medical component, no criminal component, no fire, none of that, 988 is the number to call. That is the, mental health 911, essentially. And it's the 988 crisis counselors that are embedded into the 911 department that Mark was talking about. When a mental health call comes in, they'll transfer that call over to the crisis counselor. Mm-hmm. But those 988 call takers are only embedded into the 911 center during those high volume hours. 988 is open 24/7, and they can link to mobile crisis, to outpatient, to text follow-up programs, to all sorts of different programs that are more directly accessible through 988.
Can anybody call there? Or
Anybody.
Just, oh, okay.
It's literally the nationwide mental health 911.
And what we're really working on through all this programming is what we call direct dispatching. So for instance, if I go to a call and there's a telephone pole down and I need to reach out to someone, or there's a sewer that has blown off, the lid has gone, and I need to get DPW, it is working, and 911 will call and coordinate those efforts and then dispatch them directly. Dispatch them at 3 o'clock in the morning, right? This is the infrastructure that we're talking about and building that fourth lever.
Mike?
Mike?
Good afternoon. My name is Mike Mallara. I'm Executive Director of Catholic Charities here in Syracuse, and thanks for the opportunity to address you. I wanted to share a little bit of information about the services that we provide. We have a homeless shelter for men located at 1801 Erie Boulevard. Connected to that complex, we have 8 supportive apartments for individuals who are ready to leave shelter and live on their own. Closer to this location, you can actually see it from City Hall. We have our intake center and our hospitality center. The intake center is located at Cathedral Emergency Services right by Columbus Circle. The intake center is open 24 hours a day, 7 days a week for any housing vulnerable or homeless individual. They can come to the intake center. We will process them, and we will transport them to the most appropriate shelter location, or if there's not a shelter bed available, to a hotel room. So we have been in that business for over a year now. We have probably processed hundreds, if not thousands, of individuals who have come through needing shelter, and we're very good at figuring out how to get them to shelter, including our own shelter on Erie Boulevard. In February, we opened a hospitality center in the same building. The hospitality center is open from 4 in the afternoon till 8:30 in the morning. The hospitality center is designed for any unhoused individual who refuses to go to a shelter. When we opened the hospitality center, we imagined that we would have maybe 8 to 10 individuals that would come every night. We peaked at about 25. The hospitality center does not offer a bed. There's comfortable seating. We'll have a snack. There's staff that are available to you. Our first goal is to try to talk you into going to a shelter rather than spending a night in a chair. The hospitality center has been on hiatus for the past several weeks. We've had to step back and reevaluate our staffing for it. We had an unfortunate incident where one of our guests attacked one of our staff, and we needed to step back and figure out, despite having security in the building and security that patrols the area, we are still trying to figure out the best way to offer that service, but expect to have it back up and running in September and certainly ready for the winter months. So these are services that are currently available. No questions asked. Folks can come in really in any condition, and we will figure out a way to house them. We do all of these services in partnership with Onondaga County. And while there's a lot of conversation about coordination, I do want to share that as a service provider, we coordinate pretty actively with other service providers on behalf of the people we serve. Can coordination be better or more centralized? I think there's always an argument for that, but I don't want to leave you with the impression that it's non-existent. The last service that we provide, and we do it through HUD, is permanent supportive housing. This can be a very controversial service. We serve about 300 individuals who are chronically homeless. Many of the folks that you're talking about that you're encountering on the street or having difficulty with end up with Catholic Charities, end up in one of our apartments. We work with private landlords to provide this service. If your question is, where are most of the apartments? I will tell you that they're virtually all in the city of Syracuse. If you were to ask me where the people we serve come from, whether it's our shelter or hospitality center or for permanent supportive housing, I will tell you that virtually everybody we serve comes from the city of Syracuse. And when they have the opportunity to get an apartment, they have the choice to select that apartment depending on the landlord we work with, and virtually all of them want to continue to live in the city. So I feel like this is the appropriate forum for us to discuss the needs of city residents, but because for sure the folks that we're serving all started off living in the city of Syracuse and want to continue to live in this city and be seen and be part of this city. I'm happy to answer any questions that you might have.
One of the things that I have heard that Catholic Charity has been successful at is containing their participants in their building and in their space. How have you been able to manage that? And what's the level of coordination between Catholic Charity and other organizations to really empower that form of assisting people?
I think you're referring to what we've done at our shelter at 1801 Erie Boulevard. I think we've had to work, well, first off, the perfect is the enemy of the good. And I will tell you that what we have, I think, is a good response. It's not a perfect response, and that response can change over time. But a number of things that we did very, very actively early on was we engaged the neighbors to understand what their concerns were first and foremost. We had to be brutally honest with folks about what we can and can't do. As good as we are at Catholic Charities, we are unable to control human behavior. I wish I could change that, but it's not possible. So we work within those limits, and we also spend a lot of time talking to our residents to find out, why are you leaving the premises? Why are you leaving our property? And we heard things as simple as there's no shade. It's a great, wonderful, brand new building, but we sit out here, we're going to bake. So we created places for shade. There's no place to recreate, so we created places where guys could do their workout outside and be outside. We use things like fencing to control the pathway of some of our guests so that they're not encroaching on businesses in the area. We hired more security and have security that actually patrol not only within the building, but patrol the actual surrounding buildings and the businesses. We got basically an MOU with all the businesses to allow us to patrol their areas. If we see any kind of activity, we contact law enforcement immediately. So those are just some of the steps that we have put in place. It's not a finished product. We'll continue to work at it, but it seems like for at least right now, we've been able to manage that type of behavior. Our last goal is to get a police camera installed. I think it's easier to become a saint at the Vatican to get it, and it's not the police department's fault by any stretch. It's other stakeholders that we're working with. It's just been very challenging to get that camera installed. The police department's been great, by the way. There's others that we're working with.
How often do you have availability in your apartment? How often do you have availability in your apartments or beds?
How often?
Vacancies.
Yeah, sorry, I have some hearing. We don't have a whole lot of vacancies. And out of the 300 individuals we serve, I will tell you that they're some of the hardest people to serve in the community. At any point in time, there's probably 8 to 10% of them that were really, there's 30, or less cases that can be, really super challenging. It's usually 4 or 5, but we don't see a lot of vacancies, and it's permanent supportive housing, so we really intend to allow them to live there permanently and do everything we can to prevent them from being evicted. They can be evicted by the landlord. They have been evicted, but we know if they're evicted, they're going to end up right back on the street or right back in a shelter.
Thank you, Mike.
Thank you.
My question will go to anybody from the county? She just did? Oh, I guess I'll hold it.
Chief, I was just wondering, if all these great folks that deal with the issues we just were discussing, is there any meeting that happens with the downtown merchants too, where we meld these two groups together so we can identify people in need?
Yes.
On a regular basis,
Yes.
that is? Okay.
Yeah, we work very closely with America Trier. For the downtown, we try to push a lot of things through America. But on the southern downtown, we work with our partners down there as well.
Okay. The Allen Foundation, then?
Okay.
Excuse me?
The Allen Foundation, then, you work with?
Yeah, I think that's where we've seen our most progress is, thank you very much. Yeah, our most progress is in the southern downtown. That area has been very difficult, but in the last 3 weeks, I think we've seen our most progress in that specific area.
Councilor, their business development team is also actively involved in those conversations,
Right,
so that we're just making sure that everything's
I've
coordinated.
met the chief down there more than a few times.
And normally what happens is the phone call from, they come in a variety of different ways. They come in, Michael, I, the deputy mayor, the mayor, will all get together and say, okay, what do we have? I just had one in Genesee and Geddes today, right? It's a lot of the same issues, business developer, hey, this is what the problems are, this is what I'm seeing. Okay, these are the solutions that we have. We bring out a team, I'll call Michael, hey, what can NBD do? How do we do this? Maybe reach out to Sue. That's how the system
I'm
works.
glad you mentioned that, because I didn't.
It's almost like I knew where you represented.
Well, being a representative, I met with the owner of that plaza yesterday, and there's
Yeah.
2 vacancies now because of the issues. We all want to feel empathy for the folks that are having issues, but sometimes it's really difficult for business people to deal with, and for their customers to deal with, too.
I'm sorry, Counselor. We have dealt with this in other places, like the Rite Aid on Butternut Street, right? We're walking out the door. The number of times that I have been told in the last 18 months that I'm either moving out of the city or I'm walking out the door, and we have stopped that, is countless. The service providers in here, the police officers that are actually going out and doing this stuff, we've gotten very efficient at solving problems in the short term while we build these long-term solutions like the fourth lever that I keep calling.
And I do want to compliment, especially the younger officers and Chief Cecil and yourself, who have dealt with this on a one-to-one basis. It seems to alleviate a lot of those situations, so I appreciate that.
Hi, everyone. I'm Megan Stewart. I'm the director of the Housing and Homeless Coalition of Central New York. I just want to touch on a couple of things. One of those is the coordination. So we've hosted a monthly meeting, our street outreach meeting, since I started this job 6 years ago, and prior to that, that involves the Syracuse Police Department, all of the street outreach teams, the mobile crisis teams that you've heard from today, and the downtown committee. That is a case conferencing meeting that we talk about individuals case by case. Since caseloads and we have more people outside than we ever have before, we're reframing some of that to be a little bit more effective, to talk through some of these places that pop up with a little more congregation than we've had before, to really parse out who's hanging out outside and who needs housing. I do want to touch on our ability to house folks through the homelessness service system. We've talked a lot about coordination today, and I think in our what is called HUD's Continuum of Care, we have one of the gold standard collaborative efforts to address homelessness in the country. We've been recognized previously about our street outreach approach here in Syracuse, and we're doing what we're supposed to be doing, engaging folks, trying to get them housing, offering it to them, offering to get folks into shelter in that approach, not having criminalization efforts. And I just want to thank the police department for being such great partners on that historically. But the reality is we're only able to house 15% of the people experiencing homelessness through our HUD funding each year. So programs like Mike mentioned with permanent supportive housing, they have a 97% success rate, but those beds aren't turning over their permanent subsidy, and there's a cutoff for how many people we have to serve. Fortunately, we're able to prioritize those who are in most need, but housing isn't one size fits all, and this is scattered site housing, so it is complex, and I think there are a few pieces missing in our homeless response system that could be more congregate, permanent settings for folks who need just a little bit more care on site. Something we're doing, I know Mike did mention that there's some concerns with permanent supportive housing at the coalition, is trying to coordinate some property owner engagement and landlord engagement going forward so we can expand housing opportunity so folks have choice in where they're trying to live. Oftentimes, this is a population that we have to kind of be salespeople to get housed. So we're trying to centralize those efforts and really dig into that, because ultimately, homelessness is a housing issue. There are plenty of people who misuse substances and have untreated mental health who aren't on the streets. People are on the streets because they don't have housing, and that's really where we're trying to focus a lot of effort, is that centralization. So I just wanted to offer that to everyone as well. Thanks.
Thank you much.
Sharon Owens, Deputy Mayor. Just to 2 points, Council, you began this conversation that much of what we're talking about today goes beyond the individual serving the city directly and the county directly. To the point of we are a housing first community, meaning we want people in long-term stable housing before they're in shelters. Many of the organizations here provide supportive housing. As an advocacy statement on the mic in a camera, where they may be able to find housing, it was just stated how that's hard enough, they are woefully underfunded on the supportive part. Woefully. For every dollar spent to find housing for an individual and house them, you need 10 times the money to wrap around them and to make that housing successful. And many of the issues that particularly the district counselors come into, these are individuals who are trying to find their way. And many times there are predators looking for them because they know they're trying to find their way and they're dealing with their addiction or their mental health. And so on the mic, on camera, these agencies for supportive housing, the housing side, they will argue it's not enough money. But on the supportive side, not even close. Not even close. Thank you.
Thank you. So with that, we see, you want to say something? Okay. We see that there's from the supportive side to with the service agencies to trying to figure something out from the government side of making sure that all of you are talking to each other. I think what the county is doing with hiring the director to Chief point, that may move us closer to that centralization factor, right? From the supportive side, I guess we got to figure out how to make sure that those people that are in the street, right? How do we get them into those few housing that we have? How do we use my father's kitchen services that is going out to make sure that at least these individuals are sustained daily and supported daily with the little resource we have, right? You want to?
I just want to jump in and answer that, if that's all right. We do have a coordinated housing system for that purpose. Unfortunately, what we have to do with our restricted resources is prioritize the most vulnerable. So everyone who's on the street and engaging with Rescue Mission or in my father's kitchen is being assessed for what's known as our coordinated entry system. And that's the front door to all of our housing programming. And what we do then is through that assessment of vulnerability and length of time homeless, we match people with those housing opportunities to make sure they're connected. So that's a system that I would say runs really efficiently and really well. There's just not enough resources on the back end to support everyone who needs it.
Okay.
But there is a lot. I don't want you to walk away thinking that system's not coordinated. It's extremely well coordinated, and every organization in this room is connected into it.
Hey, Counselor, just real quick, the other thing to get back to is that we have lots of overlap, but being on the street is not does not indicate that you are homeless. Mm-hmm. So a lot of the people that we do see during the day on the street go home to a bed at night. So there's a lot of overlap, certainly, but it's not we don't have everyone all sitting in exactly the same situation.
So we got to start thinking about, especially what the Catholic Charity just said to us, right? In terms of folks that are in the street, as Councilor Pat Hogan just said about business, when these individuals are in the street, it become a concern for some, right? So how do we give them that dignity by creating a space where they live to not have to go outside to go look for recreation, to go look for, what's the other stuff Mike had mentioned? Shade, right?
Exercise.
How do we make sure that if they are a rescue mission, that there's those services where they don't have to go in the street and get into issues that they shouldn't have gotten into in the first place?
Yeah, Catholic Charities, I think, really deserves to be recognized for the fact that they've had a very iterative process as they've moved into the new space to each time a challenge came up, working with the business owners, with SPD, with NBD, and other departments as we pull them in to be able to address it. And that is why we do see the fact that that's been a place that a lot of times people wouldn't necessarily know that shelter is there.
Mm. Thank you.
Hi, good afternoon. I'm Michelle McElroy. I'm the Chief Program Officer from ACR Health. And I think one of the things I'd like to just push into the conversation is about specifically this question of where do people go during the day? This is one of the things that came up in our meeting last week. And one of the gaps, the significant gaps that exist, is around where it is that people go, where space that people can go during the day, because even if they have a shelter bed, they can't be there during the day. And if they're in certain types of supported housing, be that transitional or permanent, it may not be a space that they want to be in during the day, or it may not offer some of these other resources that they need access to. It's also true that a space like a hospitality center is a great solution to that. It's also true that there's only one. It's also not open right now. But I think that in reality, we would really benefit from a more specific approach to drop-in, low-barrier drop-in spaces where people can be during the day that would be off the street, that would have access to hospitality resources, not just food, but also some of these service providers, low-barrier referral sources. And this feels like a great opportunity for a pilot, is the truth, sort of in different spaces in the city, to do some combination of CDBG funding with supplemental funding from a foundation, perhaps, in order to demonstrate how a drop-in center space like this can meet people's immediate needs, right? Again, because Maslow says if we don't address people's basic needs, then they're not going to be able to focus on anything else. If I don't have a safe place to sleep, I'm hungry, I'm exhausted, and I'm not safe, I'm not going to engage in other levels of higher care. And that those centralized spaces in different neighborhoods act as a community hub, not only for coordination, yes, but also as a place where service providers can then go and say, like when we go to the reverence space and say, we're here, we have testing, we have resources, we have staff, what is it that we can help you with here where you are, as opposed to expecting people to go to one place in town or expecting people to make it all the way across town. Because as we identified last week in the meeting, this is not just one place in town that is a problem zone where people are congregating. There are multiple separate arenas where that is happening. So expecting that all of those individuals, many of whom have no transportation and no resources, are going to somehow get to a different part of town is pretty unrealistic. Even if we put flyers in every food pantry about where they can go, are they going to be able to get there? Right? We need different hubs in different places where people can get there by foot and know that it's a place in their community that they're familiar with, so that they can go there and access those entry-level services in a low-barrier way. And then if they need or are ready for higher threshold services, service providers can push into that space and have that opportunity to almost market the services that they do have. It's also true that overall, those spaces can act as a way to screen individuals for low-barrier housing. I mean, it's perfectly clear that we don't have enough housing. I think everyone knows that. But in particular, we don't have enough affordable housing. And yes, subsidies is one piece of that, but another piece of that is simply just about housing stock, affordable housing stock, right? Not everyone needs a subsidized apartment, but people need an affordable, safe apartment, even if they don't have a subsidy, and we simply just don't have enough affordable, safe housing. We do scattered site vouchers as well. We have relationships with landlords that will work with us, but the reality is there are simply not enough landlords and not enough affordable housing units, period, even if we had subsidies for everyone.
As far as the drop-in centers, okay, so we don't have any of the drop-in centers currently.
We have a recovery center.
One.
Correct,
Okay.
one. We have one hospitality space, which is soon to be reopened, but not currently open.
Yep.
In the winter, we have warming spaces, and during heat emergencies, we have cooling spaces, like at the library. But none of those spaces actually fulfill this low-barrier drop-in center space for people who can sort of come as they are, no matter
I
what.
wanted to more or less speak on the service provider aspect that you mentioned could possibly be in the drop-in centers.
Embedded.
And I'm only speaking from a pop-up type of avenue where these shelters let out at the same time every day. The service providers know those times per se, right? And my thought is, why aren't they showing up at let out?
I think a lot of service providers do show up at let out.
Okay.
It's also true that in general, I think it's important to make note of the fact that people are encouraged to scatter upon release from shelter. They're not encouraged to maintain being in that space because of the community concerns that are voiced about people congregating near those spaces. So they are encouraged to depart.
From so many feet from the shelter, or like once they are a little bit
Well,
out?
so many feet from the shelter, but then when I move to that so many feet from the shelter space, perhaps local businesses are then encouraging me to go 2 more blocks down, which is why we move from the 500 block to the 700 block, right? Because the reality is that we're not making a space for people to be, and if people are outside, they're going to be outside. They have to have a place to be that doesn't require them to be outside congregating, or they're going to be outside congregating. There's no option, right? They're not welcome to go to playgrounds. They're not welcome to go to parks. They're not welcome to be in public businesses if they're not buying things. They can't use most bathrooms, right? They don't even have a place to go take care of basic necessities like using the restroom, because if they're not a paying customer, they're not welcome to enter many of those spaces.
And they're encouraged to disperse.
So
They are encouraged to
Yes, they are
disperse.
not welcome when they.
And I'm not saying that that's a concerted effort on the part of PD. It's not. It is really our community response about stigma, about pushing people who are not understood and who are seen as being problematic, troublesome, burdensome, instead of understanding the root causes around substance use, around mental health, around lack of affordable housing, that the people have nowhere to go and they don't know where to be.
So, just a quick follow-up on that. One of the reasons that we've seen Catholic Charities be successful with their new shelter is the fact that they do work to make sure that people feel invited in and able to stay during the day. And so that's why they've created the space outdoors. They've bought games. I know Mike has left, but that's been really successful with the fact that they are trying to consistently pull them in. I do think that we also want to look at this from a slightly bigger perspective, and the fact that, as we've talked about, this is, we're talking about multiple different issues. When you look at the amount of opioid funds that were awarded, they were awarded to the city and to the county. They were awarded based on need, and you'll see that the county got significantly more money than the city, and that's because addiction does not know boundaries. Yet, when it comes to service, all the service exists within the city of Syracuse. And so then that makes it significantly harder for people that are trying to, and housing as well.
Absolutely.
Absolutely. You all, as a body, have been beyond supportive of creating the first zoning code that we've seen in New York State that requires affordable housing. And you all know intimately the fact that none of our neighbors have done that. Mm-hmm. We still end up in that same situation when it comes to all of these other services, in the fact that it is incredibly difficult to get any of our neighboring communities to be willing to support their own residents in the way that we do. And so we end up being asked as a community to solve that problem. And so when you look at all of these challenges that we're talking about, it's a Central New York challenge that is reflective of a national challenge, but in Central New York, it's Syracuse that's asked to solve the problem.
And many people are afraid. Working in pharmacy, retail, people are scared. How many times a person would come, and this is right, where Reverend Pastor Bishop Alex said earlier, coming into the drugstore, confronting a customer, disturbing them, wanting to their money, going and waiting for them as they try to leave their vehicle and they can't, or being threatened. These are real things. Mm-hmm. People are living in dumpsters. We go out and there's somebody sleeping in a dumpster for the night or for the day. We had a poor situation for years. This person played basketball at Syracuse. I didn't know who he was. He was down on his luck, and he'd come in every 10 minutes. Give me a few bucks. Give me my natty daddy. And I'd say, no, you're done. You need help. You don't need natty daddy. You need help. And we would call the Wood Police and try to get him help. And people were just making his situation worse. Here's a couple bucks. And he'd come in the store and says, no, you need help. Why aren't you buying food? And what he would do is he'd take the food and he'd put it in his pants. Well, so be it. It's better to do that than try to ask somebody for natty daddy. And it was a terrible thing because you witnessed it firsthand. But I know there are success stories.
Absolutely.
There is, and we don't hear that. There's success stories.
It's tough to report on something that didn't happen, right? And so the day that someone was able to be successful, that's the wins that this community is aware of, but it's difficult to measure.
I wanted to ask Sue really quickly if you would speak on is there anything that the county is doing to push any affordable housing on a 50, 60% AMI or lower rate? Oh.
Yeah, so Deputy Mayor.
Councilor, each municipality has its own codes, just like we do, zoning codes, et cetera. It is on record how progressive and liberal our zoning code is in what can be built in the city of Syracuse around housing. Outside of those boundaries, I can't say the same.
Yeah.
And so for much of the housing that is on a supportive nature, you're going to find it in the city of Syracuse.
Yes, John, again, in my father's kitchen. I wanted to address the councilman's, I know that you all represent a constituency behind you, right? So you're their voice. I get all that. So for you guys who don't know, my family I started Asti Cafe on North Salina Street on the 400 block. It closed in 2019. I opened it in 2002, and I left that behind to do the work of In My Father's Kitchen. So I understand that side of the fence. As a business owner, we own the property. We since sold everything off. So I feel the pain of the individual who's the property owner, the business owner, because that was me.
It was me, too, John, it was me too, so.
Yeah, I know.
I was on South Ave, though.
Yeah, I get it. But I think the missing link, though, there's a missing link. I know that you're the voice of the people behind you, but I think we need some community partnership active, like business owners not coming to gripe, because we know there's the problem. It's more, can you come and be part of the solution to the problem? Because I think there's a lot of brain power as business. I'm an entrepreneur. I do not-for-profit work, but I think like an entrepreneur. So I'm marrying the two things together. I do customer service on the street. I used to do it in a restaurant, right? I think we need that brain power in the room, and maybe even some physical resource from those individuals who could bring solutions to help all of us here, to help the person that's suffering on the street. I think it could be a beautiful story if we could give business owners to participate in a greater capacity to engage this community, maybe to have jobs for these guys. The guy who's panhandling in front of your store, well, can you wash your windows? Can you make this relationship, this connection between the two, right? So I think I just wanted to say that I get where you guys are coming from because I was on that side of the fence, but I'm also doing this. So I just wanted to say we need their presence in this room.
John, still got your eggplant recipes?
Marcus, I wanted to ask you one last question, and maybe you can answer this too. So when you're encountered with a situation where there's a person with a completely different set of beliefs based on culture, and maybe not even be able to speak English, how are we handling that?
Yeah, so we started a bunch of programs probably 4 to 5 years ago, but don't quote me on it. But separate language. Language was one of the primary concerns that we had because we have so many different languages that are spoken in the city of Syracuse. So we engaged with a program. When I first started, you would use a family member, right? 18 years ago, and that is problematic that we've seen because maybe that person is the abuser, they're the suspect involved in the incident, maybe they're not. Maybe you're using a child because the child's in the school-based setting and it's not inappropriate. So that's really how it started 18 years ago for me when I was a street cop. You didn't have an alternative resource. We have some officers in the PD that you would rely on, but they didn't speak all of the many languages that we have. So right now we have a couple of things. One is Voyance. That's our biggest application where we have it can either be face-to-face or it can be auditory. We have a lot of folks that have ASL. We have some folks that are NSL for Nepalese Sign Language in the community. So we use Voyance as our primary default response for folks with English as their second language. That was part of your question. The other part of your question was cultural beliefs, right? So we've pushed cultural competency in many different programs. I've been here before to talk about Lemoyne and the work that we've done with them in terms of understanding the history of Syracuse and the Syracuse Police Department in this specific community. But then also we've pushed with Dr. Strauss is his name, if I remember correctly, where we have folks that come in and will teach cultural competency and emotional intelligence. And we have a series of programs that we use at the Basic Academy. We'll refresh them during in-service, like your continuing education, where we will have these programs to address that. So one is more operational, where if I have to come to you, you only speak Spanish, and you're trying to report a crime to me, I don't have a Spanish-speaking officer that's on, I would get into the Voyance app. The other thing, too, that the city, when they negotiated a contract or a tentative agreement maybe 2 or 3 times ago, they gave a specific incentive to incentivize officers who do speak a specific language. So it used to be it wasn't as important, maybe for lack of better terms, to have folks 18 years ago when I came on, if you spoke a second language. Now it is. We are contractually incentivizing that. I think that was a huge step in the shift of SPD to be understanding of what population we serve and how many different languages we have. Yes, ma'am.
I think most, if not all, human service agencies in this room could say a very similar answer as far as our response to language and culture. Most people who are left know I have a lot to say. Okay, so two things. One is piggybacking on your comment earlier, sir, about success stories. So I think it would serve all of us and all of you really well to have this room not be full of community providers, but be full of people who are in recovery. I think you need to hear stories from them. And my second thing, I wanted to piggyback on places to go. This is a wild idea, and I know a lot of people balk at it, but there's a lot of really positive research about it. So I shout it from the rooftops wherever I go. I think we need a safe use center. I think we need a medically monitored place. People are going to use drugs. We are not going to stop people from using drugs. That's just not going to happen. That would take a really big magic wand that none of us have. If we had a safe use center, research shows that it decreases crime in the area. It definitely decreases overdose deaths. We had 155 opioid-related overdose deaths last year. We had well over 1,000 reported uses of Narcan that saved somebody's life. That's only reported. That is not counting all of the things that were not reported. If we had a medically supervised place for people to test the drugs that they're using and to receive medical care in relation to, I mean, even what John was talking about, the skin-related things that are happening now with some of the drugs that people are using that are expanding into infections, and then they're just dying on the streets from infection. I know it's a wild idea. I know that a lot of people are afraid of it. We're talking about fear, right? And also, where are you going to put it? Because the local business owners don't want that near them. But if we have research, oh, Tom left, or this stuff is still here, but we have research. It actually shows that crime in those areas decrease.
Okay. I know we're going to be closing soon, but come back. I wanted to ask because you brought it up. So I have recently learned about these drug testing kits. And do you guys have research that people are testing the drugs and they say, oh, it has this horse tranquilizer in it, I'm not going to use that?
Yes.
That's my $10 down the drain.
Yes, there is data out there that demonstrates people make the choice not to use drugs that are more likely to kill them. Of course, that is not a blanket statement. There are still people who are going to use the drugs regardless of whether they know what's in it or not. So what we say for one is not what we say for all. Everybody's recovery journey is incredibly unique, just like a fingerprint to them. And so we have to build our system to the many, not to the one.
Part of the New York State Department of Health drug checking pilot, and we not only do drug checking with test strips and education with clients around how to use those through peer-delivered syringe exchange in our fixed site syringe exchange on our mobile unit at Dudley and Fitch, and also through rideabouts at other counties. We also have embedded spectrometer lab equipment at our office so as to do live drug checking at the point of care for individuals who bring those supplies in and want to have them checked. What we find is, yes, some people will not use those drugs. Some people will use those drugs, but they will know what to expect, and so they will reduce their dose, thus being less likely to result in an overdose, fatal or non-fatal, but at least not likely to result in an emergency call. And what we are finding is that real-time data around the adulterants in the drug supply, by feeding that back in the aggregate to the state and to local health departments, allows for law enforcement, the high-intensity drug trafficking task force that we work with, to also have information now, as opposed to in another quarter, which is a look back around all of the overdoses that occurred, and then we're trying to do overdose fatality review instead of understanding right now what it is that's on the street.
To wrap it up, I want to go back to you, Chief, about especially, I know that we have mechanism in place, things like liberty resources and how we filter through 911 to make sure that we are sending the right appropriate SPD members to the place. what has that done to your policy of in terms of who you arrest? And although you were called because of a violent situation, what has all of these knowledge and all of these learning has done to your SPD policy and approach?
So I think the approach is fairly formulaic at this point, right? And I use the dangerous panhandling detail as a prime example. We selected specific officers, just like we do with crisis intervention training. We select specific officers. We train them, we educate them, we really embed the expectations, what the goals are. And in this scenario, everything that we've talked about, mental health, substance abuse, mental crises, the goal is to divert these programs as much as we possibly can, because we've learned the lessons of criminalization of poverty, substance abuse, mental health. It never solves the problem. And police officers are very pragmatic folks. They want a solution. They want to be able to see, they don't want to deal with the same problem over and over and over again. Just like I think many of the people in this room, they don't want to see the same problems over and over again. But one of the things that I think we've learned as a police department is we are going to deal with this over and over and over again. And that's where I really have to give a lot of praise to the local captains, the command staff, and the police officers, because it, just like for these folks, it's incredibly grinding on you to come in and deal with someone one day and come back and deal with the same problem over again. You don't feel like you're making the progress. Data in this area is very hard to collect, right? You know, when John was here, he's talking about individual people. 371 people over 13 years. That's a great number, but that's really like a basic descriptive statistic. I'd like to be able to tell you that this program that we're doing with Friendly Faces has reduced everything by X. The data just doesn't really exist that I can see. I don't want to speak for the service, but this is really difficult data to collect. A lot of it's anecdotal. You know, you get an email from someone to say, hey, things have really been much better. Things have been, worse in this area. A lot of it is anecdotal information. Unfortunately, we just don't, the police department does not have great data on success stories, for our side. So in terms of our policy, I think there is a cultural shift that happened. We have very good young officers who are very compassionate. They're also, Deputy Chief Trudell, who runs the Investigations Bureau, he's been very aggressive with people that are preying on these folks. We are separating in the efforts that we're doing. We're trying to intentionally separate folks that we can push in with a pop-up event, or service providers, the people that are using, as opposed to people who are distributing. We handle those folks significantly different, very aggressive. And Deputy Chief Trudell and his detectives have done a great job identifying, and just in the last 4 weeks, we've conducted 3 search warrants on people that were preying just on Dickerson Street, right? And we're going to continue to be aggressive as they move around. We have really impressive detectives that work for us.
Do you have a similar situation over at the Samaritan Center? Because this time people will go there to prepare for dinner now.
Yes. Yeah, we have.
They're there.
Yeah. Yes, we do. We do. I mean, this is terrible. There's problems. I do think we're making slow progress.
We're fighting those who are preying on us.
Yes.
Yeah.
Thank you, Chief. Commissioner, with all of this, it seems like you are in the center of it all. What's the next step for us, or at least something that you are coordinating to it seems like everyone is doing the best they can with what they got. From the city perspective, where are you with this to continue to empower these individuals, and maybe from what we have talked about, what are some of our actionable?
So, Counselor, I often go back to a housing analogy for a lot of things, right? And that is the fact that I think that what you've seen over the last over this period of time that Deputy Chief's talked about is we've been building the foundation. So we've talked a lot about, well, why are people in this situation, as Councilor Nave started in the beginning, and housing being an answer. everybody wants to be able to provide for themselves. You started and ran one of the most unique programs in the community to be able to do that, where when someone came into the community center and needed help, we would ask, why do you need help? Why do you need the pantry? And to the point around tough data to collect, when somebody stops coming to the pantry, is it because they got a job? Is it because they moved? We don't know. We don't know what the success rate is. But if we got them involved in a program where they could help themselves, where they could provide for themselves and provide for the family, that we knew was the chance for long-term success, right? And so you made sure that your staff was able to do that. When you look at what we're talking about here around all these challenges, the housing comes first. And once the housing is there, to Deputy Mayor's point around the wraparound services, we need a lot. There's stuff that we can control, and there's a lot that we can't. Councilor Jones-Rouser, you talked at the beginning about the fact that this was, addressing some of these issues that are 80,000-foot issues. I wish you were right when you said they were 80 foot, right? I mean, we can see that, right? So the challenge here is some of it we control, some of it we don't. So it's a multi-pronged approach. One is, as we create the housing, how are we making sure that there's the wraparound services that include being able to give people the opportunity to stand on their own 2 feet and to be able to say, I have control over the addiction that I'm challenged with. I have control over my mental health in the way that so many other people in this community have control over their physical health. I have an opportunity to stand up for myself and go to work every day and feel empowered by bringing home that paycheck and feel self-worth. We need a lot of that. We can collectively work on the components of that we can do. And that's what you see with what we're talking about with pop-ups, to what we're doing with housing, to what we're doing with all the workforce initiatives. We need help in advocating for policies at the state level that work for upstate New York. We need help advocating at the federal level so that these funds that all these fantastic organizations use, and frankly the HUD funds that we use, have some flexibility to meet our community's needs. And locally, we need help from our neighbors. We need this to not be a Syracuse solution to a community problem. That's what we need.
Deputy Mayor, you got anything you want to add? He did it? Okay. Okay. Anything else, councilors? If nothing else, I want to thank all of you. Thank you for coming and sharing your time with us and your knowledge. Chief, Commissioner, Deputy Mayor, my colleagues, this will do it for us. Thank you so much. Have a good night.
Thank you.
Thank you so much.
Yeah, it's great to see you again. Thank you. You too. Take care. Okay?
Surprised nobody gets us here.
Yeah.